Hello, and thank you for joining. I'm Kevin Wayne. I lead our analytic advisory practice here at Truven. We're really excited to conduct this webinar today. I am joined by two of my colleagues, Catherine and Brandy. Going to the next page. Oh, there we go. So I lead our analytic advisory practice. I am joined by two of my colleagues. I've been with Truven for 20 years, and I've been in healthcare for over 30 years. Working in healthcare analytics, I work day to day with our clients on analytic advisory and strategy, and I work with a team of consultants who work day to day with clients. Catherine Shanahan has joined me, and Brandy Hodor. They will go ahead and introduce themselves as they go into their sections. They're going to be going into a deep dive into use case and strategies and data strategy. So we're looking forward to a great webinar. We appreciate everyone coming. First, I want to just kick off with a couple of housekeeping items. One, this will be recorded, so you will get a copy of the recording as well as a copy of the deck. If you do have a question, there should be a Q&A icon on the right, and so just feel free to fill that out. And then any questions we will answer at the end. And then if we don't have time, we'll follow up in writing as well. So please take the time to ask those questions. We do have a poll here to kick things off, and I see people are already starting to fill it out. We just want to see what is top of mind, right? What keeps you up at night? We have some key trends that we put in here. We know pharmacy is top of mind, mental health, cancer. Please fill us out. We will share these results, but we just thought we'd do a quick round robin of the poll to see exactly what is keeping people up at night as we drive into these strategies. So we will share this as part of the presentation. To start off, I'm just going to give a little background on Truven. I know we have many clients on the phone as well as some non-clients. So first of all, I wanted to just remind, and I know this, people know this, that we acquired Springbook in September of 2025. So this is super exciting. It's really kind of bringing the best of both worlds together. There's a lot of synergies between our organizations. And here, the depth and breadth and the reach across the healthcare ecosystem is very large, right? We have, we're talking about Truven, we have 40% of the Fortune 100 employer clients. We have 7 of the top 10 payers, 17 of the top 20 pharma, and then 7,500 plus for Springbok small and mid-market employer clients. So really, there's so much synergy in what we're doing together. So bringing these two is a really exciting time for us. And there's a lot of synergies, and really our depth and breadth and our market reach has just really expanded. So again, super exciting for us here. Just a little bit to just talk about just the foundation of what we're having and why it brings together. So we're talking about Truven, Health Insights, Springbok, Market Scan, all under that Truven umbrella. What ties it together first is data, right? And we're going to be talking a lot about data today. Data strategy is really part of what we're doing when we're talking about trend and trend mitigation here. So as part of this, we got to get the data right first, right? So we have best-in-class data management, and then again, that is core to what we're doing here. So we're working with our clients across the ecosystem, pulling the data, cleansing it, and it starts with that foundation, that solid foundation of clean and cleansed data. And again, we will be talking about data strategy quite a bit as part of this. The next is the analytic models themselves. So the best-in-class analytic portfolio, from episode groupers to predictive models. We'll be hitting on one of our newest predictive models today, classifications, measure sets. So everything that is going to move trend and measure trend and also predict, right? We need the context around, as we look at trend, what is the context? What is the why? And what is going to happen, right, with our predictive analytics? We also have Market Scan as our best-in-class benchmarking, and I will be talking a bit about that because we've pulled in Market Scan data as part of this presentation. So I want to talk about that, but as we have our best-in-class benchmarking solution, and we're talking about trends today, we need to benchmark to say how we're doing against a benchmark, right? If I am doing well in trend, that's fantastic, but how do I compare to the US norm, right? I may be trending well, but I'm 20% off from the US norm. How do I compare to my state? How do I compare to my industry? So having those best-in-class benchmarks embedded in our solution is key. And then also really just that consultative partner and working with clients really across, meeting them where they are. We have all different clients and they have different staffing models and how we're working together. But a core thing is we're really partnering with clients to meet them where they are. We have clients who have extensive top-notch staff, right, from data sciences to clinical teams, but they're looking to partner with us to drive strategy, right? One thing we want to do is share what other clients are doing and best practices, right? We're working across a lot of different clients. We have clients who actually use us for staff augmentation, right? We really are part of their team, and we're the analysts doing their work. And then just clients who are just looking for SME support, right? But the common thread there is really being that consultative partner and not just that vendor relationship. So again, I just want to kick off for a little information about Truven and the exciting time that we're pulling in Springbuck and really the synergies of bringing those two together. All right, and to just talk through the agenda really quick, I am going to start at a high level and just talk current state, really kind of that macro view. What are the trends that are being predicted? What are the insights we saw for last year? Talk about data strategy a bit. And then Brandy and Catherine are going to dive in some deep use cases, right? We know what is actually driving trend and what really is top of mind for our clients. So we're going to tackle GLP-1s, gene therapy, physical, mental, financial health, and then wrap it up with a Q&A. And through this all, that data strategy is going to be part of it because we want to be able to talk about the data we need to bring in order to move the needle, right? This is all about moving the needle. The trend has been going up year over year, and 26 is actually predicted to be quite high, which we will be talking about. All right, so I just pulled in some examples here of trends that are being predicted, and they're really consistent across the board. But just to drive home, right, the 2026 is shaping up to be one of the most expensive years in the last decade, right? And we've had some expensive years, so that's saying something. So health plans at a 10-year high cost, employers 7.6 to 10% of total healthcare spend. Medical trend 8.5 for a third year in a row. Pharmacy, you'll see a $50 billion year over year. This was for 2024, but it doubled from the prior year. And as we talk through our statistics as well and our focus on pharmacy, that is a key strategy that we can't ignore, right? So this current state of what is being predicted for 2026, in addition to what we've seen in the past, really drives home why we're all here today. The strategies that we need to put into place to mitigate this trend and really move the needle. So again, just a state of the state and some of the predictions, and it really is across the board. I wanted to give a little information based on market scan. I talked about, Truven has Health Insights, which are our analytics solution, end-to-end analytics solution. Even we have freestanding analytic models. We have Springbuck, and we have market scan as well. I want to talk about it because we're actually going to be going through some market scan statistics, and I know we have clients who are heavily using market scan, but all people are not clients on the call today. So I just want to give a little background just to give context. So MarketScan is our research and benchmarking database, best-in-class closed claims database. You'll see in the bottom right-hand quarter, there's 37 plus billion records, over 300 million patient lives dating back to 1995. So this is used really across the industry for a lot of things: health, economics, outcomes research, pharma. We have clients who are using it for pricing strategies. Actually, last year at our Trends webinar, we discussed pricing strategies, right? That when we're looking at trend, we can't ignore price because price is going to be a driver for us. So we went through the different pricing strategies, and one of those is your contracting strategy, right? So we have a reimbursement benchmark cut as part of this. So you can model contracts. So we want to be able to look at Medicare pricing. We want to be able to look at the machine-readable files. We want to see what is actually happening in the market with actual paid claims. So that's just an example of the different cuts that are available and the way we deliver MarketScan to clients, in addition to embedding them in our tools. And that's really what we're going to be talking a bit about today is really the benchmarking capability, right? Whether we're giving benchmarks to our client or they're using our tools and pulling them in, we need to be able to show how we are trending to an external norm, right? It's not good enough to just look at how my data is trending. Again, I could have a very positive trend, but I am far off from the US. I'm far off. Let's say I'm in Wisconsin. I need to look at Wisconsin. Wisconsin's very different. Or if I'm in California, California is different. How am I trending compared to my state? Industry as well. If I'm in retail, the retail industry is very different, or automotive. So all these different cuts are available in MarketScan, and they are key when we're talking about managing trend and moving the needle. I need to know how I compare to that external norm in order to know where to focus. So again, just want to give a little background on market scan just to set the stage for stats that we'll be going into. So, and speaking of market scan, I pulled some market scan stats into the presentation, right, to talk about what actually has happened in the past, right? We're talking about what's we expected to happen in 2026. We need to look at what is actually happening, right? And again, these increased trends are not new. We've been experiencing them for some time. This is a view of market scan semi-annual employer norms, and it goes through mid 2025, right? So it's a full year, but it's a rolling year. We don't have a complete data set for 2025 yet. Obviously, claims are still coming in. But you'll see here that the increases are significant. If you look at the 12.1% increase of medical and RX allowed amount per member per year, that's almost $1,000 per person. So just multiply that by the population so you're managing. Though that trend is extensive, right? And again, we have a large prediction for this year. And this is why we're here. We need to manage this trend, and we need strategies around it. I have in the middle, the top 1% of members are driving 29% of costs. And we know, and we've known for some time, that a small portion of the population is driving a large portion of the cost, right? And this is showing significant, right? Almost 30%, 1% of the members almost driving 30% of the cost. But we want more strategies around this, right? We know all of our clients are reporting on high cost claimants, but we want to get more predictive about that, right? If someone's high cost today, they're probably on our radar. But what if someone is low cost today and they're going to become high cost? What if someone is high cost, they're going to be significantly higher cost? We want to use machine learning and AI analytics in order to identify these people to intervene early, right? Who is going to have a big spike in costs, and then what are the drivers? Brandy's going to go through a use case around that of a new predictive model, identifying those members so we can intervene early. And again, when we're talking about trend, we have to focus on the people who are going to be driving those costs. And here we're showing it 1%, almost 30% of the costs. When we're talking about pharmacy, and pharmacy will be a big topic today, if you look in the lower right-hand corner, it's almost 20% is being driven by prescription drug, right? So we're looking at the per member per year, which is over 2,000. So it is the highest. It's going up to 2,418. So it's a $400 jump and almost a 20% jump in prescription drugs. And we're seeing this across the board. Again, this is our market scan data, but pharmacy is going to be a key strategy as we look, and Catherine's going to be diving deeper into that. If we look at the upper right-hand corner, I have here that 19% of the total RX spend for brand name drugs, so this is just looking at brand names, I wasn't looking at generic, the top 4 drugs alone were driving 19% of the costs under brand name drugs. And those were all GLP-1s. So Wegovy, Ozempic, Zepbound, and Mounjaro, right? And GLP-1s will be a big topic today, as I'm sure it's a big topic for all of you. I don't think anyone goes to a meeting today without hearing about GLP-1s and the impact, right? But we need to be able to do more analytics around that. Are they working? Are we moving the needle? Are people getting healthier? Are people adhering? Are we lining up the right people, right? And we want to bring in new data sources in order to look at those analytics and really show the value or where we need improvements in these programs we put together and to justify the spend. If you look at the middle, we have at the bottom, it's mental health, which is a 15.5% increase. And one thing I just want to note here is when you're looking at these different buckets, for those not familiar with our analytics and our tools, this is one of our methodologies. It's service categories, and we're taking all of the claims and applying service categories. So every claim line is put into a mutually exclusive bucket of cost utilization, right? So when I'm looking at my trends, I'm easily able to see if I spent $40 million last quarter, where did those dollars go? I need to be able to identify and bucket those. So for the mental health, you'll see a 15.5% increase. Brandy's going to go through strategies around mental health, and we know the mental health impacts physical health. And this aligns with the national trend in order to have more mental health services. There's an increase in the demand out there, and we're seeing it in the data. So Brandy's going to discuss that as well. And then also just really across the board, you see there's increases every category, right? These aren't small increases. And I would say one of the things I would just want to point out is these are the type of analytics we want to drill into, right? And we're talking about our strategies. Service categories is a great example. When we're looking at where these costs are happening as we drill into the detail, one of the strategies that Brandy's going to talk about is site of service optimization. We know that if you have the same service at an inpatient hospital, an outpatient hospital, an ambulatory surgery center, or an office, and it's all clinically appropriate for the same service, the costs vary drastically, right? The cost for the payer and actually even usually the members out of pocket, right, based on their benefit design. So site of service optimization and steerage to the appropriate lower cost setting when clinically appropriate is one of the strategies, right? And we want to use these analytics to drill into that. So again, just a view into market scan data to really drive home what's been happening and the analytics around that. I would also point out that if any client is on the phone that, I would encourage you to work with your Truven team on analytics if you're seeing anything interesting. I'm sure they're diving into this today, but happy to repeat any of this on your data as well. But this is really the importance of benchmark, right? We need that external view in order to drive change and understand what's going on. And then I want to just talk about, and end here before I turn it over to Catherine, of the importance of diverse data types. So this is, paramount to really kind of what we're doing today, right? And I have just a comment on the side. You can't manage what you can't measure, and you can't measure without data. And that is key to what we're talking about today. And I would say the data strategy is paramount to what we're talking about here. The analytics and everything, but we're removed from that world of just medical, pharmacy, eligibility, provider, and maybe lab data, right? We're bringing in all types of data sources. And if you are looking at a holistic view of a member, there's all different indicators that are really telling us where we need to focus. We need those data types in order to do that. So you'll see here on the wheel, I've outlined a lot of different data types. It's not all inclusive in any way. We're bringing in over 50 different data types for our clients today, but this really does need to be part of the strategy in order to move the needle. That data management and bringing in the right data sources, it's not just about more data, right? It's the right data that we're going to bring in. And again, Brandy and Catherine have some great examples. But if we go through just very quickly, claims data will tell us what happened, but it won't tell us why. We have wellness and engagement data. It captures behavior, but not underlying risk. Productivity reflects impact on health and work, but not clinical drivers, right? So we want to complete that full picture, bring in all the clinical data, medical and pharmacy, on-site clinic, patient-centered medical home. So we really understand the utilization patterns and clinical needs. We have lifestyle and behavior from HRA, incentive, wellness, so that behavioral context. Financial and productivity, which is really interesting, workers' comp, disability, but Brandy's going to be going into financial health as well, right? Years ago, we would never brought in a 401k feed, but what does it tell us about someone if they're not contributing to 401k, if they're taking out 401k loans? Are they financially stable? If they're not financially stable, that can impact physical health. And also avoiding care if you can't afford it, right? So all these different drivers are part of the picture, and even health equity, right? We're doing a lot with health equity and social determinants. We're bringing in the CDC Social Vulnerability Index for clients, race and ethnicity data. So again, it really gets back to that full picture. And then once we get that full picture, we can identify risk earlier. We can target interventions more precisely. We measure program more accurately, right? Part of this is proving what is actually working and what's not working. So we need that program evaluation and ultimately improve the outcomes. That data strategy is a huge part of this. And the last thing I just want to leave you with, and it occurred to me as I was putting this slide together and thinking about what we were going to talk about, right? And the importance of the data that, just last quarter, we did a success story with one of our clients. Our clients are doing some fantastic work, right? We always want to showcase success. And Blue Cross and Blue Shield of Alabama was a great health plan partner of ours and has had amazing outcomes with, supporting members and advancing member outcomes, supporting providers, showing value to employers, really moving the needle. And we just published this success story with them last quarter. And one of the quotes, and I've seen this through their decks through the years, and we put it in the success story, it's really become a mantra for them. And it's an MIT quote. And that MIT quote is, data has a job to do, and that job is always about a decision, right? And I think that really drives home, and their success is really a part of that data strategy. And what we're talking about here with all these different data types, it's about data strategy, and we need to have it. A strong data strategy is really non-negotiable at this point when we're looking to mitigate trend. So I just want to set that context, and Catherine and Brandy are going to go into some specific use cases in the data types that we need to pull in order to do those analytics. And before I turn it over to Catherine, I just want to show the poll. So it looks like pharmacy is the top with 67, almost 68%, led by cancer and mental health. So very timely. So as I turn it over to Catherine, Catherine is going to dive into GLP-1s. So very exciting. Appreciate it.
Awesome. Thanks, Kevin. Hi, all. My name is Catherine Shanahan. I'm a senior pharmacy analytic advisor here at Merative. My background's in pharmacology and toxicology, but I've spent the last 13 years working with payers on managing healthcare and prescription drug costs. So we're going to kick off today with talking about the leading driver of prescription drugs trend, GLP-1s. So this is a graph that many of you have seen before, with now 2025 completed. So GLP-1s have been on the market for over 20 years now, with Byetta, the first GLP-1 approved back in 2005. But it's only been in like maybe the past 5 or so years that we've really seen exponential growth. So the graph here is market scan data, trends, patients per 1,000 and allowed amount PMPY from 2013 through 2025. And then along the x-axis at the bottom is the timeline of FDA approvals of different products. And so we see utilization's really skyrocketed. It went from 4.8 patients per 1,000 in 2013 to 88.4 per 1,000 in 2025. And then likewise, allowed amount PMPYs followed suit from $13 in 2013 to $700 in 2025. And so this rise is due to a couple different things. It's not only have GLP-1s become kind of a standard of treatment within diabetes, it's really only metformin that has kind of exceeded in utilization rates. But it's also expanding into the kind of broader obesity and weight management, especially in the last year or two where it's really gained momentum. If we go to the next slide. So this is, again, a slide that many of you will be familiar with. It's looking ahead at the GLP-1 pipeline. So at the end of last year, we saw the first obesity GLP-1 oral medication come to market, Wegovy pill. And we expect around March of this year, orforglipron, it's just going to be a second oral obesity medication, and it'll have a different name once it comes to market. And then possibly one more this year. Possibly CagriSema might also come to market towards the end of 2026, maybe into 2027. And so these new approvals, they're going to kind of possibly expand within the obesity market. They're possibly going to increase spend additionally this year. So really understanding how these products intersect with the ones already on the market, like Wegovy or Zepbound. And then in 2027, we also expect a couple new approvals, some of which are going to compete directly with products that are already on the market, which might lower costs. But others are really going to offer some advances in like cardiometabolic management, which those medications might be priced higher. So there's going to be a little bit of duality. In 2028, we're expecting the first specialty drug in this area, bimagrumab, which again, going to have a different product name once it comes to market, but that's going to be used with kind of some of these traditional GLP-1s, and it will help focus weight loss on fat instead of muscle loss. Finally, into 2029, 2030, and beyond, again, we're going to have kind of a duality of approvals. We're going to see some of the current products in the market come off patent, and so some generics will come to market. But we're also seeing that there's possibly going to be some gene and cell therapies. Specifically, there's ones being worked on that are going to restore beta cell function, which is one of the primary drivers behind insulin resistance and diabetes. So as you're kind of thinking about these trends, as you're thinking about this expanding number of products in this market, how they're going to work together, how you're going to set up your formulary, I know that there's a lot of questions around, are patients seeing clinical value in these medications? Is there an offset or like ROI demonstrated through like health improvements or mitigation of disease progression? Or should we be curbing this trend and like reducing access? So go to the next slide. So this is exactly the kinds of questions that our account teams have worked with you all on over the last year. And really each payer is going to have unique circumstances that are going to lead to successes or failures within the space. And so in the second half of 2025, we asked you all to complete a survey on your coverage of how GLP-1s, how it's changing. How did you cover these medications in 2025? And then what were your plans for 2026? And we got some really fantastic results. In total, the payers that completed the survey cover 6 million lives, span a number of different industries, and spent $2.4 billion on GLP-1s in 2025 alone. So I want to first thank you all for taking the time to answer the survey. Actually, your account teams are going to be sending out details on how your answers compared to others, as well as how that impacted your utilization and spend trending. And for anyone who hasn't had a chance, we're going to include the survey link to today's follow-up call and some of the follow-up information. But first, let's take a look at some of these preliminary results. So the graphs here look at formulary coverage of GLP-1s with diabetes products on the left and obesity products on the right. We thought it was really interesting that we saw really minimal changes with diabetes. There's only like a 3% shift in coverage from like preferred to not preferred coverage tiers, but otherwise 2025 to 2026 plan years for diabetes product coverage stayed pretty consistent. On the other hand, on the right, we saw very big shifts as it relates to obesity product coverage, which aligns honestly with what we've heard anecdotally from you all throughout the last year. Specifically, we saw a 10% coverage shift in obesity products from like preferred or preventive to not covered at all. So in fact, this is a common trend we're actually hearing across the industry, either the tightening or complete removal of coverage for obesity GLP-1s. And so for payers that have dropped these from your formulary in 2026 or are considering it for 2027, we recommend really tracking the care of these individuals. Do they migrate to other care options? How are they progressing in terms of metabolic regression or severity? Do they, and I think most importantly, are there opportunities to still kind of support these patients through weight management? So for example, I know some payers are exploring options for HSA funding or rewards programs that could then be used to offset the cost of these weight management treatments. Let's go to the next slide. But the coverage of these GLP-1s and their placement across formularies really varies by industry. So here we see 4 industries as examples, so finance and insurance, healthcare, manufacturing, and universities, and how they cover diabetes GLP-1s on the left and obesity GLP-1s on the right. So for example, for finance and healthcare, diabetes GLP-1s are frequently covered on the preventive cost tier. So that's in green, usually like no out-of-pocket for patients. Meanwhile, like manufacturers and universities are putting these medications on like a preferred or even not preferred tiers, which is like in that blue and purple. And so some of that's going to then shift some of that cost burden to patients. For obesity GLP-1s, we saw even more variance, especially with the rate of payers not covering the medications, and that's what's in red. And so we saw specifically like manufacturing patients and payers in 2005, it was really common to not cover obesity GLP-1s versus universities. It was a little bit more common. But even that seems to be changing. So specifically for universities, we saw a 30 percentage point shift from 2025 to 2026. So in 2025, 14% were not covering obesity GLP-1s. In 2026, that's jumped to 46% not covering them. So these kinds of shifts are exactly the kinds of discussions, to understand where you guys are looking next, how you're thinking about covering in this space or working through this space in terms of management. And so for those continuing to covering obesity GLP-1s, I think one of the largest changes that we've heard, for example, is the addition of weight management programs. So the percentage of payers requiring weight management programs for access to obesity GLP-1s has grown 5 percentage points going into 2026. And that's specifically driven by manufacturing and then finance and insurance payers. Go to the next slide. So there's a lot of different weight management programs and point solutions that have come up. And, we're working with you all on a lot of these different areas. So they cover everything from weight management and obesity. Sometimes it's more directed at diabetes, and sometimes even broader into like broad cardiometabolic management. And so these programs work in a number of varying ways. So some are digital and telephonic interactions, there's coaching, some of them are narrow prescribing networks, some are collecting biometric information. Actually, one of them is duplicating all your biometrics to kind of make a duplicate clone of you to see how that influences in the type of health outcomes and things like that, depending on what you eat or what kinds of treatment you're receiving. And so when you're considering these programs or currently working with a program vendor, it's important to understand how to integrate them within your benefits and with your other healthcare vendors. So first, this includes setting really clear expectations. How do members navigate to the program? Are they encouraged to enroll through like a well-being reward, or are they going to be required in order to access GLP-1s? So some of that old carrot versus stick decision. You also want to define the specific behavior change that you're wanting to improve. So do you expect participants to see better clinical outcomes? Do you expect participants to have better adherence or persistence to treatment, or possibly reduce side effects, for example, through like coaching and education? Also, data collection is really key. And this includes not only like engagement data, but any of like that submitted biometric data or survey data from your members. So these data points help us understand how the program might be improving the outcome expectations and where there's opportunities to improve in the future. And then lastly, most importantly, you want to consider, how does this program integrate with your other vendors? You don't want it sitting out on an island, right? How does engagement data and biometrics get shared with that patient's physician? How do we look holistically to better understand why some patients succeed and why some patients are failing? And can we demonstrate the outcomes for patients offset the cost for the program, for example, producing like an ROI or a business case for our leadership? Next slide. So finally, manage all of these benefit intricacies, the vendor impact and the patient outcomes takes good data and integrated data. Integrating medical data with prescription data helps us understand if GLP-1s are being used off-label, if we're seeing high prescribing rates for certain physicians, or if a patient's missing medical care that's crucial for that holistic treatment. We know GLP-1s garner high rebate amounts, but missing vision into that data piece can lead to formularies that don't align with value, especially as we think ahead about this like product pipeline and all these new products coming to market. How is that going to work within your benefits? Where are we going to put different products at different tiers? Are we going to have step therapy? And how do rebates factor into that? And then setting clear and measurable expectations from vendors and programs help us understand the ROI and impact from biometrics and lab data that helps us see like that clinical improvement well before claims data, to productivity data that demonstrates how health improvement can influence kind of beyond the patient beyond healthcare. Even survey and HRA data, which I know can be flawed in some cases, but it helps us understand the attitudes and behaviors of patients, which might help us tailor like communications or even the benefits that we're offering. And then integrating these pieces to help track a patient across their health journey and kind of look holistically at how these different benefits are impacting their outcomes and where their successes and where we're not succeeding. So with that, I'd like to talk also a bit about gene and cell therapies. So as we look ahead to where the pharmaceutical market's going next, we're seeing a significant increase in the number of drugs that fall under the umbrella of precision medicine, or maybe also known as personalized medicine. And there's a number of subcategories under precision medicine. There's targeted therapies, which target like a specific protein. So you may be familiar with like a drug that targets a HER2 protein for breast cancer. There's immunotherapies, like CAR T medications, which like amplifies a patient's immune system to fight the disease. And then finally, gene therapies, which delivers genetic materials to help a patient like change how their cell kind of works. And so these gene therapies are really often administered in a hospital setting, maybe inpatient or outpatient. And so they're covered through medical benefits, which is a bit different. Some of the targeted therapies and whatnot are through our prescription benefits. And so while the cost of these gene therapies can reach sometimes hundreds of thousands to even millions of dollars, the total cost for treatment actually exceeds beyond the drug. There's some cases where these gene therapies can just be infused. And so maybe the patient just needs, some basic supportive care, maybe some wraparound ancillary care. But in some cases, these are really, highly complex, treatments where the gene therapies, especially like ex vivo gene therapies, the total cost of care might involve like inpatient stays at highly specialized hospitals, follow-up care, etc. And so currently there's 40 gene therapy products on the market, treats conditions like hemophilia, cancer, and then a number of different rare disorders. But we're going to talk a bit more later about how this area of medicine is expected to grow pretty significantly over the next 5 years. So here we're looking at cell and gene therapies, or CGT, spend and utilization and market scan from 2022 to 2025. Again, looking at allowed amount PMPY, and then it's patients per 100,000. I also, again, have that timeline of FDA approvals along the x-axis at the bottom. So I will note that currently 2025 appears a bit lower than expected, but I will say a lot of times these medications, there's a bit of a delay in terms of how they're paid. So I'm expecting as we complete 2025, that's going to go up pretty significantly. And then although these medications are really costly on an individual basis, their PMPY impact has remained relatively low due to the rare nature of the conditions for which they're approved for. But if you remember back at my earlier slide on GLP-1s, and I quoted that back in 2013, GLP-1 PMPY was only $13. That's where we're at today with gene therapies. They're just starting to pick up momentum. And we start to see that from 2022 to 2024, the utilization rate grew 42% and PMPY spend doubled. And we're expecting this to continue to grow in the next few years. If we go to the next slide. So this is the gene therapy pipeline, or cell and gene therapy pipeline. So it's showing the number of late-stage medications that are nearing FDA approvals for gene therapies in green, cell therapies in blue, and then gene-modified cell therapies, or GMCTs, in purple. And it's broken out by the types of conditions that they're going to treat. So it should be no surprise, we've talked about this bit, but oncology is one of the fastest growing areas here, with nearly 500 new medications on the horizon for cell and gene therapies. That's followed by neurological disorders, which includes medications for conditions like Parkinson's and Alzheimer's. So anyone with retiree plans or older populations, that's something to keep an eye on. Metabolic disorders, which is at the kind of far right of that graph, is one that actually shouldn't surprise many of you. At previous Health Insights webinars, I've shared that there's a number of gene therapies and cell therapies that are being developed for type 1 diabetes. And looking further down the pipeline, I'm also expecting some of these to expand into type 2 diabetes in the future. Go to the next slide. So as you're looking ahead and considering how to cover or budget for these types of medications, we're recommending really leaning on your vendors for a partnership on management. The conditions that these medications are treating are highly severe and often require rigorous testing to confirm the patient will even find success with the drug. So leaning on your health plan and your provider groups to develop detailed medical policies to ensure that the various lab tests and radiology tests are accessible and covered by benefits. You also want to consider how newly diagnosed patients navigate these requirements, right? So we're seeing payers like take advantage of navigation programs or rare disease care management to aid in this. And then in terms of cost containment, we're seeing payers kind of explore innovative payment models. So models like COEs or bundled payment or value and outcome-based payment models, like Brandy will talk more about these a little bit later, but specifically for certain conditions like cancer, that's really going to expand in terms of this kind of precision medicine going into the future. And lastly, we're seeing payers weigh their options for things like stop-loss insurance or multi-payer risk-sharing agreements in the attempt to spread out costs over time versus being hit with some of these like extremely large claims all at once. And so it's really important that to understand what's included in these agreements, any limitations on like what won't be covered by them, and then how these agreements are going to change over time with the approval of new CGTs each year. Go to the next slide. So what can you do about this growing treatment class and how can data help? So first, I want to emphasize the importance of comprehensive data. Reporting on precision medicine means that your data needs to also be precise. Unfortunately, there are some known gaps with claims data and ICD-10 reporting that often mask some of the precision that's necessary to validate treatment or track a patient's outcome in this space specifically. Often supplementary data like lab data, EHR, or even care notes can start to become really important in this space. I will say, fortunately, CMS is rectifying some of this. Actually, in October of 2025, nearly 500 new diagnoses were added to ICD-10, which is double the amount that was added in 2024, with many of these related to the diagnostic specificity for these types of conditions where CGTs are used. And so we still know that there's gaps, though, in recording these. So if providers are not actually recording those new diagnoses, if they're not included on claims, that's going to be really difficult for us to do downstream reporting capabilities. So one of the priorities for payers is to make sure that these diagnoses are used if a gene therapy is going to be used within treatment. Next, as you explore alternative payment models and risk-sharing agreements or vendor partnerships, it's really important to set clear and measurable goals and to define the expected outcomes. Developing preliminary projection models and agreeing on expected savings opportunities will reduce your risk for wasteful spending. And then lastly, we've heard from you all on how important tracking the drug pipeline is. That's why it's always included today, especially as it relates to expected expenditures for new medications and how to identify management opportunities before you get hit with these, huge trends or huge claims. And so throughout all of this, it's data, industry expertise, and this collaborative vendor partnerships that's absolutely key for future management in this area. So with that, I'm going to hand it off to Brandy, who's going to talk a bit about how payers are finding balance.
Thank you, Catherine. So my name is Brandy Hoder. I've been with Truven for 15 years, with my prior years spent at both a health plan and a community health system, driving financial analysis. Today, I'm a senior analytic advisor here at Truven, working with our employers and health plans to see that healthcare chessboard and choose the smartest moves going forward. As we head into 2026, more employers and health plans are working to achieve a balanced approach for their members. And as Kevin mentioned, we're seeing continued rising costs. And as we heard from Catherine, pharmacy costs are only expected to increase as new high-cost drugs are coming on the market. Focus is being put on how we can balance the costs with the benefit. Think about it. Today, nearly $1 in $5 spent in the U.S. economy goes towards healthcare. So how do we find balance? Achieving balance requires payers to evaluate not only medical and pharmacy expenses, but also to further assess the interplay between physical and mental health, as well as financial considerations influencing member behavior. Physical health, for example, encompasses management of chronic conditions such as diabetes and asthma, addressing weight-related issues like Catherine talked about, and even obtaining preventative healthcare services. All of this helps members stay healthy and avoid costly ER and admissions. Common mental health issues such as anxiety, depression, and substance abuse have led to the 15% rise in mental health substance abuse that Kevin mentioned that we've seen in our semi-annual norms. Additionally, members' mental health may be impacted as they deal with family with chronic conditions such as cancer, or if they face the challenge of being a caregiver for adult children or aging parents. And then the third piece of the puzzle is financial. Payers focus on helping their members and families achieve financial security, often providing options like 401k plans, health savings accounts. By storing this information in a data warehouse, payers can track member contributions to these programs and identify the plans members choose to join. Payers invest heavily in programs and vendors to support their members. As healthcare costs continue to rise annually, these initiatives are expected to only increase. Payers continually assess plan design to ensure it meets members' needs. Let's look at two such plans. We've got PPOs and high deductibles. While both PPOs and high deductible health plans hold members accountable for usage, they produce different outcomes. Market data factoring in the CDC Social Vulnerability Index based on the neighborhood minority percentile shows PPO members visit the ER more often across all neighborhoods than those with high deductible health plans. This directly impacts the shared cost for payers. And because PPOs do not require coordination by a primary care physician, this may result in reduced preventative care, limited chronic disease management, and an increased risk of conditions escalating into emergencies. Conversely, what you see here in the second graph, we start to see that high deductible health plan members typically have higher rates of adult preventative visits per 1,000 compared to their PPO counterparts, regardless of demographics. This is likely due to the fact that under federal rules, high deductible health plans must cover preventative services at no cost to the member, no deductible, and no copay. Recently, more payers are exploring alternatives beyond traditional PPOs and high deductible health plans for employees and their families. So, if we shift the accountability from just PPOs and high deductible health plans to include providers such as those in an ACO, a PCMH, a narrow network, or bundled payments, we can better share responsibility and manage costs. As a trend, we're seeing more payers and even specifically more employers are exploring ACOs and value-based care models to guide members into these plans. These models shift the care away from volume and towards value. So now we're targeting quality over quantity, preventative care and early intervention, and really cost-efficient pathways. This aligns with payer strategies to control long-term costs and trends while improving the member experience. One impactful method we recommend involves assessing the risk of rising healthcare costs, like Kevin mentioned. The model we have, the risk of rising cost, represents a prospective risk score that evaluates several factors. Machine learning and AI models play a critical role in this process. It is well documented that a significant portion of healthcare expenditures are attributed to a relatively small segment of the population. Remember, Kevin showed us 1% of the members are accounting for 29% of the costs. Recent market scan data demonstrates that among individuals categorized as high cost in any one given year, approximately half do not remain in the highest cost group in the following year. More than 400 variables drawn from medical, pharmacy, and eligibility data contribute to this model. This includes age, gender, disease categories, specialty medications, recent inpatient costs. So collectively, these measures enable the model to predict the likelihood of rising costs, the probability of inpatient admission, primary risk drivers, and the anticipated second-year expenditures at the individual patient level. By utilizing models like the risk of rising costs, organizations can more effectively target their value-based care programs to positively influence members who are at risk for rising costs. An additional approach to addressing the substantial physical costs associated with member care is the implementation of site-of-care analytics. This capability remains one of the most significant yet underutilized tools in contemporary healthcare strategy. It sits at the intersection of cost, quality, and access, helping organizations understand where cost is delivered, why, and how these choices affect outcomes and spending. It's the discipline of analyzing data to determine the most effective and efficient setting for delivering care. Organizations use this analysis to reduce unnecessary high-cost utilization, improve the patient experience, and optimize resource allocation. So we now are applying cost optimization, quality improvement, patient access expansion, and value-based care performance. So what are some such examples of this? Shifting elective surgeries to an ambulatory care center, optimizing infusion therapy sites, or managing high-cost imaging utilization. Our primary objective is not to eliminate services, but rather to ensure that the care is provided in the most cost-effective setting. Now let's focus on mental health, like Kevin mentioned. Since 2020, mental health has emerged as a significant priority among payers. Using similar graphics as before, we examined PPO and high deductible health plans across neighborhoods by the percentile minority populations. Neighborhoods with a lower percentage of minorities are marked in purple, while those with higher percentages appear in green. Notably, rates for mental health services increased up to the middle percentiles, then they declined sharply in areas with the highest minority concentrations. This tells us that those that live in neighborhoods with the highest minorities are not receiving services for mental health. Remember, it only shows a lack of claims, not a lack of mental health need in a population. According to the National Alliance on Mental Illness, 23% of the U.S. adults experience mental health conditions, a figure that continues to grow annually. This means that more than 1 in 5 adults are affected. Let's say we have a group of 1,000 members. That means 230 are facing mental health concerns. This could be depression, anxiety, substance abuse, or others. Additionally, over 120 million Americans reside in federally designated mental health professional shortage areas. Telemedicine usage patterns reveal that individuals enrolled in high deductible health plans utilize these services far less than those with PPO coverage. And especially is concerning, once again, are those highest areas of minority concentration that are not utilizing these services. Mental health has a notable impact on mental health, on physical health. 12.3% of emergency department visits made by U.S. adults annually are related to mental health conditions. Overall, serious mental health illness accounts for $193 billion in lost earnings annually across the United States. Employers should prioritize addressing mental health in their workforce, as its impact will only intensify in the years ahead. Many payers are now partnering with various programs aimed at improving mental health. As you engage with these different initiatives, consider the types of data you can collect. This information can help you better understand your population. By combining this data with claims data, you can gain a fuller picture of overall well-being. Payers want to help their population basically remain healthy and productive, make lifestyle changes, manage chronic conditions effectively. As payers implement health programs to aid these efforts, they need to monitor the effectiveness and value of those programs to inform future strategy to ensure they're targeting the right members. So what can they do? Evaluating point solutions in healthcare has become a mission-critical skill for payers. The market is overflowing with vendors. There's over 300 plus solutions across 20 plus categories. And most benefit teams are small. Without a disciplined evaluation framework, it's almost impossible to separate meaningful impact from some polished marketing campaigns that they're feeding you. To better understand whether your point solution is having an impact, either an ROI or a VOI, a point solution evaluation will measure the following 3 components of your program. The engagement, are the right people engaged? Behavior change, is your solution addressing those areas it was intended to address? Improved medication adherence, targeting mental health, and then what are the outcomes? Is there meaningful change in the downstream outcomes among those who are participating? This could be lower costs, less unexcused call-ins, reduced BMI. It's estimated that between $30 to $50 billion is spent on healthcare point solutions every year. Payers need to hold their solutions responsible for engaging the population and producing outcomes. By evaluating the point solutions you are using, you can better understand if they are delivering on promise. And then the last piece of the triangle, the financial data. Payers often collect extensive financial data, but don't always integrate it with medical information. Key data includes provider payments, salary, 401k and HSA contributions, program premiums, and other relevant metrics. Combining these sources in a data warehouse can offer a comprehensive view of each member. True financial analytics in healthcare requires examining factors beyond claims, such as affordability and medical loss ratio. These insights impact financial performance and influence population health. Integrating financial data allows for enhanced reporting and measurement. Payers spend a lot on benefits. They don't often know whether those benefits are helping, so looking at financial indicators helps. Employees who are financially stressed are more likely to experience lower productivity, more absenteeism, higher turnover, greater use of mental health benefits. So when payers look at HSA and 401k contribution patterns, they get a window into whether employees feel financially secure enough to save, and then lower participation can signal strength. It's It's a data-driven benefit strategy instead of guesswork. The key is that employers look at aggregate, anonymized data, not individual employee finances. The goal is to understand trends like, hey, are lower income employees unable to afford the deductible? Are younger employees not saving for retirement? Are certain groups opting out of HSAs because they don't understand how they work? These insights can help employers build a healthier, more financially stable workforce. The Mayo Clinic actually released a study in December, and in fact, CNN had an article covering the study just last Friday. The study found that individuals with higher financial stress and food insecurity often showed signs of accelerated cardiovascular aging, regardless of traditional risk factors. This means people of similar age and health profiles could have different heart health based on their financial strength. Financial stress tends to be chronic, involving ongoing concerns such as bills or debt, unlike temporary stressors. Notably, the impact of financial stress on heart aging was as significant as or greater than established risk factors like high blood pressure or diabetes. The research highlights the importance of considering social factors like financial stress and food insecurity alongside clinical risks in assessing heart disease. And so, what can we do about this? While we are examining solutions for physical, mental, and financial wellness separately, integrating them all into an algorithm will actually allow you to move your data along further. We've had clients come to us and say, hey, we're looking for something that's actionable insights. And so what we have done is we've created what we call an opportunity score based on their needs, based on their data, to really apply a score to each person based on all the rich data they have in their warehouse. So if this is something that interests you, you can let us know more. And then as we go into our last slide, so what are some of the takeaways? What can you do? You can evaluate the feasibility of implementing, a value-based care initiative. You can definitely incorporate data from mental health partners to gain more comprehensive insights. And then you can examine your financial data to see if there are, challenges influencing the performance or retention and decisions about benefits within your population. Now let me hand it back to Kevin for final comments.
Thanks, Brandy. Appreciate it. We are running short on time, so if we haven't answered your questions in chat, we will follow up in writing, as well as sending out the deck and the materials. Just to recap, data strategy is paramount here, and we've talked about it quite a bit. Catherine gave examples of different data sources that we need to bring in for, the GLP-1. And we're looking at biometric screenings, lab results, rebate data, engagement data. Brandy brought it up as well, right? Is really core to what we're doing. And again, we're bringing in over 50 different data sources for our clients today. So it's really kind of paramount in order prioritizing what we need to bring in, right? Really, what is going to move the needle? What programs do we have? But that data strategy is key. Analytics must be advanced and accurate, right? We talked about the data foundation is paramount, right? We have to get the data right, and especially these nuanced advanced analytics. The data matters, but also the different data types we're bringing in, and then the models we're applying to it. Brandy went through a new AI model that we've created, which is fantastic, right? Targeting people that we need to look at, people who are at risk of rising costs. So just a great example of the analytics and the clean data underneath it. Also just leveraging industry experts, the vendors you're working with, but it's also just collaborative as we're working with clients. We pull our clients together to bring our summit or bring our clients to share best practices. We have client roundtables, right? Our clients are doing amazing work. We all want to learn from each other, right? And even just this webinar, hopefully we've accomplished a bit of that today, but it's really kind of sharing the information. So working closely with that vendors is key as well, and working with your peers. And we do that when we pull our clients together. Next page. Just as we're talking about insights, again, super exciting that Springbuk is with us. I think there will be a link there for you to register, but they are having their trends webinar on February 3rd, as well as their full report. I've seen a preview of this report. It is fantastic. I highly encourage you to sign up. So super exciting. So again, pushing out thought leadership and sharing information with our clients. A great example here, and hopefully you can make it. Next page. And then we are going to be at a bunch of different, conferences and such, and we look for clients, and we look for clients who want to talk to us. We'd love to continue the conversation. So if you're a current client and you're going to be at these events, I would encourage you to reach out to your account team. If you're not a client today, follow us on LinkedIn. We'll be sending out information, so we would love to catch up and advance these conversations, learn more about what you're doing, and collaborate. And then also just some thought leadership, again, to the right. It's really about pushing out information, sharing what other clients are doing, and the things that keep us up at night, right? And the strategies we put to really move that needle. So again, I just want to thank everyone for their time, and we'll be following up with the materials after this webinar. Thank you so much.